Just a quick overview of some of the issues that I'd like to cover today. First, of course, being nurse workload. This is specifically what this talk revolves around. Nurses, you probably know, comprise the largest number in our workforce. There's over 3 million of them that are licensed across the U.S. Unfortunately, only approximately 2 million plus are currently working as nurses, but we do number 3 million. The effects of increased nurse workload. I'll also focus a bit on job-related burnout. Hospital-acquired conditions. Those are the ones that have been identified by the Centers for Medicare and Medicaid Services. I will then kind of focus more on healthcare acquired infections, nurse workload, and clinical practice. And I don't think we'll have time for Q&A, but if we do, we'll throw one or two in. Nurse workload, it sounds kind of like a simple concept, but actually it's a complex phenomenon. There are organizational factors as well as human factors. On the organizational side, we have reduced staffing. Facilities try to keep as few as possible on their units for cost containment efforts. And at the same time, when we're cutting back on the number of nurses that we have in our units in our hospitals or nursing homes, we have, especially in the acute care facilities, increase in patient turnover. The length of stays have shortened, so patients are being admitted and discharged on a relatively fast pace. And that, combined with the reduced number of nurses, is a kind of a formula for problems. And there's also human factors that contribute to this workload issue. Time constraints. And when nurses don't have enough time, their performance is going to change. There's no doubt about it, whether it be a nurse or anybody else in any other kind of field. If you're time constrained, you change the way you perform. There's also mental workload. And when workload is too heavy, it's difficult to have these different tasks that you're mentally trying to perform at the same time. And then we have burnout, which basically is emotional exhaustion. So, as was mentioned, I've done a lot of work surveying, doing survey research, most of the time surveying nurses. And much of the information that's in this presentation is either from the literature or from my personal research. And this happens to be from research that I was involved in a few years ago, where we had surveyed nurses in several states. And the findings were consistent. If you increased nurses' workload, they reported that there'd be a 20% increase in complaints from patients and families, 30% increase in verbal abuse from patients and from staff. And look at some of these more pronounced numbers. If you increase their workload, there were more likely to be 50% increase in job dissatisfaction, 50% increase in nurse burnout. Quality of care, 80% more likely that nurses were going to be reported as fair or poor. And this other one that's highlighted, the workload causes me to miss changes in patients' condition. It increases by 50%. Now, somebody had mentioned the concept earlier of failure to rescue, and that's where this is very important, because basically that's failure to rescue is failure to identify changes that are occurring in a patient's condition, and then, of course, things spiral out of control. And as the original definition of failure to rescue, there's been many definitions of it, but the original definition is these complications or causes, changes that are missed, then result in death. I've been involved in nurse research, survey research in Pennsylvania, and I know that there's a body of data over the last 2 decades at a minimum where nurses are reporting that there are not enough nurses in hospitals to provide high quality care. They don't have enough staff to get the work done, meaning ancillary staff. They're also important components of the healthcare team. Not enough support staff to allow time with patients. As somebody else was mentioning earlier in one of the talks, that we have to listen to the patients and what the patients have to say, but nurses are saying they don't have time for that when their workload increases. And we've also found out from nurses that for each additional patient, that's just one, for each additional one patient that we add to a nurse's workload results in a 15% increase and the likelihood that those nurses will report job dissatisfaction, and a 23% increase in the likelihood that they report that they are burnt out. And this is just a graphic. It's not showing up well here. I don't know if it is on the screens. But it's just to show you how it's a cycle that's difficult to break. But we have shortages of nurses, and I know in some states that's debatable, but I feel that we have a huge crisis looming on the horizon. And we have facilities that aren't staffing adequately. This results in job dissatisfaction, then burnout, and then the nurses leave. And it's costing facilities a huge amount of money because, number one, we know that patients are experiencing adverse events, which is an additional cost to the facilities, and CMS doesn't want to pay for many of these adverse events. And then you have to train new nurses if you have an increase in turnover, which is a huge cost to facilities. So we know workload is a complex phenomenon, but so is burnout. It's a syndrome. It's been described by Christina Masloch, who's been doing research on burnout, at least from the 70s. And she's from out in she's a sociologist in California, has done extensive amount of research on burnout. And she has identified it as a syndrome of physical and emotional manifestations. And it's especially identified in people that are employed in service or caregiving professions, such as teachers, police officers, firefighters, and a substantial amount of evidence shows that it's also nurses because of the interactions, constant interactions, these human interactions. And she's identified 3 dimensions of burnout: emotional exhaustion, depersonalization, and personal accomplishment. And so what happens in this process, this burnout process in patient care? Well, there's substantial research to show, and Masloch has said this in her work, that when you become extremely burnt out, you detach. You're no longer cognitively aware of what's happening in the environment. And some of the research has stated that healthcare providers, they feel like they no longer have positive feelings or sympathy or even respect for the patients. They're completely detached. They feel that they become cynical and almost dehumanizing a patient's perceptions. Burnout plays a primary role in the delivery of poor care. I think we have enough research to support that, and in other professions. And when you look at the research, you see that burnout is a major factor, not only in low morale, but look at this, impaired performance. So if we have a large percentage of nurses, and on average, most of the research out there and the research that I've done shows that at least 1/3 of the nurses are reporting high levels of burnout. You can't expect to have high quality health care. I don't know how well you can see these also, this slide here, but I just wanted to point out that these, on the one side is the job satisfaction, and then on the other, on the right, is burnout. And we had data on nurses in different facilities. You can see their hospitals, nursing homes, and other settings. And in every one of these, well, first of all, it's prevalent. There's no doubt in all these healthcare settings that job dissatisfaction and burnout are a problem. Now, when nurses are working in other settings, you can see it's much lower. But if you look at the red bars, these are the nurses that are providing direct patient care. So, and they're reporting the highest levels. And it kind of fits in with this whole concept of burnout, this close interaction with other individuals. So those are the nurses that are at the bedside, the highest proportion reporting job dissatisfaction and burnout. A little bit higher in the nursing homes, but in the acute care hospitals, equally disturbing. When we looked at the environment where nurses were, because again, burnout is a complex phenomenon, it's multifactorial. Not only is it the interaction with the patients from day to day that contributed to burnout, but the interactions with colleagues administrators, and other aspects of the work environment. So we surveyed nurses on the quality of their work environment using the practice environment scale of the Nursing Work Index. And we found that if the environment was poor, the overall general work environment, you had a larger percent of nurses, and that's the bottom bar in each one, I think it's greenish, reporting job dissatisfaction, were about 33% of nurses working in a poor environment report job dissatisfaction, as opposed to 17% working in a good environment. And the same thing with burnout. If nurses were working in an environment that was classified, that they classified as poor, then it was 40% of the nurses were reporting high levels of burnout. Now, this isn't just an average of it, this is high, excessive burnout. And you could see where it's about 28%, which is still considerably high, but in a practice environment that's more supportive of nursing. I thought I would include this because, well, it's another finding from our research, but I thought it was interesting on the different aspects of their employment that nurses weren't happy with. And, of course, retirement benefits. I think people are a little bit unhappy with retirement benefits in many occupations. But the health care benefits was quite surprising. I thought, oh my gosh, if nurses aren't happy with their health care benefits, I don't know what we can say about the rest of the people that are employed across America. But you can see here, especially in the poor working environment, 50% of nurses were unhappy with their health care benefits. Burnout is also, we should know, is a global phenomenon. It's not unique to the United States. I've had the opportunity to work with colleagues in a number of different countries. I chose this slide with these data points. I know it's a little bit old, but I just wanted to make a point, and things might have changed in recent years. But when you look at job dissatisfaction, you see 41% of the nurses in the United States were dissatisfied with their jobs. They're a little bit more satisfied in Canada, England, Scotland. But look at Germany. Where only 17% of the nurses were reporting that they were dissatisfied with their jobs. And the same thing was happening when we look at burnout. And again, the burnout levels, 43% of nurses in the United States reporting high levels of burnout. Somewhat similar in Canada and England. But look at Germany, again, only 15% of the nurses reporting high levels of burnout. The findings were kind of similar. I mean, we had older nurses, if you look at the percent under 30, but you know, and the others are kind of averaged out. But it was very interesting in Germany, and we were trying to figure out what could be different about those German nurses, and that's why I presented these data, even though they're old, because I know things have changed. But back then, when these data were collected, Germany had a different payment system than the rest of the countries. They had not yet adopted the DRG system, so they had a longer length of stay for their patients. There was no big rush to get these patients in and out. So they could take time. The nurses, you know, if you had a longer length of stay, the nurses had more time to spend with the patients and make sure that they were adequately addressing the psychosocial and the physical health care needs of their patients. And this is kind of reflected here. When we looked at the percent of nurses that were confident that their patients were able to manage their care when they were discharged. Look at the differences here. Only 33.8% of nurses thought that patients were able to manage their care. But in Germany, it was almost 81%. And the percent who say that the quality of health care had deteriorated in the past year, almost 45% of U.S. nurses had reported deteriorating quality of care. Some of the other countries not as bad, but again, Germany was very pronounced, very different from the other countries. Again, where they were able to, you know, there wasn't this in and out, and that's such an important, the way healthcare has changed since we implemented DRGs is very telling. We started to cut staff and we shortened the length of stay, which was somewhat of a deadly combination. Of course, healthcare quality has been on the agenda for many years now. I again believe somebody mentioned the Institute of Medicine earlier, where in 1999 we had the Sentinel report to Err is Human, Building a Safer Healthcare System, where it was reported that almost 100,000 people die every year from medical errors. This was followed in 2001 by Crossing the Quality Chasm, where deficiencies were identified in our healthcare system. There was some mention of nurses, but not much at that time. And then 2004, the Institute released their publication, Keeping Patients Safe, Transforming the Work Environment of Nurses, and stating that we were jeopardizing patient safety by the way we were staffing our hospitals and the number of hours that nurses were working, and that we were requiring mandatory overtime. So we know that errors occur in hospitals, there's no doubt about that. And a couple of years ago, the CMS had identified a number of these hospital-acquired conditions that they found were problematic, and they said that they shouldn't be happening. In fact, they were at one time classified as never events. I think that term has been dropped, but here's the list of them. Foreign object retained after surgery, air embolism, blood incompatibility, pressure ulcers, falls, glycemic control, DVT, and 3 of them are infections. The catheter-associated urinary tract, the vascular catheter-associated infection, and the surgical site infections. And those were the first that CMS focused on. And even though they are all rare events, the infections were more prevalent than the others. And all of those, if not all of them, almost all of them, have been classified by CMS and the National Quality Forum as nursing-sensitive measures. And I don't know if you can read this from the back of the room, but there's that administrator with his clipboard with Medicare nurse-sensitive measures. And the nurse at the station stating, there better be a line on that form for short-staffed, underpaid, and overworked to exhaustion measures. So why are infections so important? Well, there's over 1.7 million of them that occur annually in our hospitals. They're costing our facilities $6.2 billion annually. They result in at least 90,000 deaths. Now that other report from the Institute of Medicine said like 98,000. That was all adverse events. Infections alone, and these numbers are a few years old. They haven't come out with a new report recently, but you can see with a large majority are a result of infection. The most common sites are the urinary tract, the surgical site, the bloodstream, and pneumonia. 3 of those being device-related, the urinary catheters, the venous catheters, and a ventilator for the pneumonia. The most common organisms they're finding in these infections are staphylococci. And I'll tell you, if we went around here culturing now, I would put a bet on it that at least 95% of the people in this room have staph on their hands. So when we look at nursing care and healthcare-associated infections, there's been over 30 years of evidence. I just picked a few, or we could be here all day discussing these, but back in 1982, Haley and colleagues, they found, when they investigated an outbreak of Staph aureus, that it was linked to the nurse-patient ratio, the staffing. Archibald, 1997, had an outbreak of Serratia marcescens. It was associated with the hours of nursing care. Harbarth, 1999, another outbreak, Enterobacter coliaci. Again, the number of patients that nurses were caring for. Robert, in 2000, coagulated negative staph, methicillin-resistant Staph aureus, and Acinetobacter, Candida, Serratia marcescens, Pseudomonas aeruginosus. I mean, it just goes on. That was associated in that, they found out in that investigation, not only with the number of patients that nurses were caring for, but there was an increase in the number of float nurses. So you're taking nurses who were not regularly assigned to a unit and placing them in that unit. And they may very well be unfamiliar with the policies and procedures in a given unit. Anderson, 2002, another outbreak, methicillin-resistant Staph aureus. Alonzo, Econo, gram-positive and negative cocci and fungi associated with the use of float nurses. Manolovich, another methicillin-resistant staph, associated to the staffing numbers of patients assigned to nurses and the hours of nursing care. And Glantz, in 2002, an increase in the number of LPNs was associated with an increase in sepsis. Now, 3 of those, and I don't know if you can see the asterisk, were actually outbreak investigations by the CDC. So you can often say, well, you know, people are doing research and they're doing investigations and the findings could go this way or that way. But those were independent investigations by the Centers for Disease Control and Prevention. And they found that nursing was associated with the spread of those infections. So we had data in Pennsylvania on infections and nurses, and you might not know, but Pennsylvania was the first state in 2005 to publicly release data on infections that were contracted within a hospital. In fact, in Pennsylvania, if you're a patient and you're in a hospital and you acquire an adverse event such as an infection, the hospital is required by law to send you a letter and say that they were responsible for that. So I was working with researchers at the University of Pennsylvania, and we were surveying nurses over 4 states, and we obtained a random sample of nurses based on addresses from the licensing board in each state. And we used a rigorous methodology, and when we cleaned up our data, we found that we had data on 7,076 hospital-based bedside nurses in Pennsylvania. And they identified their employers. They were working in 161 hospitals in Pennsylvania. And we had data on them that described their characteristics, the care environment, burnout, job dissatisfaction, quality of care. We had the infection data from the Pennsylvania Healthcare Cost Containment Council, and it was rigorous because it was defined as per CDC criteria. We had hospital characteristics from the American Hospital Association, which was bed size, teaching status, and high-tech status, meaning facilities that were performing open heart and transplants and such. These were the infections that were reported for that year in Pennsylvania. You could see that there were 30,213 cases of hospital-acquired infections in Pennsylvania for that 1 year, which was a rate of 19.2 per 1,000 cases. For our analysis, we chose the catheter-associated urinary tract infection and the surgical site because, as you saw in that previous slide, they were the most common. And since when you were using administrative data, you don't know what unit a patient was on, you know what hospital they were in, you don't know the specific unit. So we chose those 2 because we figured they could be acquired on almost any unit within a hospital. We found that the average bed size in these hospitals was 227. 48% of them were teaching hospitals, 40% were high-tech, and on average, nurses were caring for almost 6 patients each. Nurses, and this was in '76, were almost 44 years of age. The overwhelming majority were female. Almost 38% were baccalaureate prepared, and on average they had 17 years of experience. 37% of them were reporting high levels of job-related burnout. You should know that we measured burnout using the Maslach burnout inventory. That's been highly validated, and as I mentioned before, there were 3 subscales. We focused on the emotional exhaustion subscale because that's the one that Maslach has identified as being the key component of burnout. We found that for each 1 additional patient that we added to that nurse's workload, resulted in a 0.86 unit increase in the rate of urinary tract infections and a 0.93 unit increase in surgical site infections, which is 1 per 1,000, which in the case of the urinary tract infections we would increase by about 1,351 additional infections per year. So, how does this all kind of play together? Well, what is the role of burnout? We found that when we analytically looked at staffing, yes, it was associated with infection. But when we put burnout into the equation, staffing was no longer an issue. It was the burnout that we found was associated with these infections. And we found that we had similar findings with the urinary tract infection, that there was a 0.82 unit increase in the rate of urinary tract infections with an increase in burnout, but the surgical infections were a little bit higher at a 1.5 unit increase. And we had determined that for each 10% increase in a hospital's composition of high burned out nurses was associated with an increase of 1 urinary tract infection and 2 surgical site infections per every 1,000 patients. I don't know how well you can see this, it's a little blurry there. I specifically copied this out of the paper because infections are a hot issue. People know about them, healthcare providers as well as lay people. And when that paper was published, the Philadelphia Inquirer, which is fairly well known, at least in the Northeast, it's one of the larger newspapers nationwide, they put this on the front page of their paper, our findings, which were, the bottom line was, if we could reduce nurse burnout by 30%, the state of Pennsylvania would save about $48 million annually. And unfortunately, what I've learned over time, and many of you probably know, it's dollars and cents that people understand. You could talk to policymakers day in and day out about infections and other adverse events, and yes, they appreciate it, but once you start telling them, hey, now wait, this just cost you $50 million, they stand back for a second. So I think as we push our research agenda and our other agendas forward, we have to always try to remember, we don't want to dehumanize the importance of these events, but the money that's involved is what actually makes them step back and take a look. So how do all these pieces fit together? Well, this is an image that was published at a conference I was at a number of years ago, and though this room looks a hospital room, it's a clean hospital room, it looks a little older maybe than some would look today, and I don't know how well the image is projecting up there, but these investigators went into a clean hospital room and they decided they were going to culture all the surfaces. And what they found, I don't know if they were shocked or not, but it was you know, a little unnerving to me anyway. Everywhere you see an X on this picture, and I don't know, like I said, if you can see them, there's one on the monitor, there's one on the IV pump, there's one on each bed rail, the blood pressure cuff, the ventilator, the patient's tray table, the chart that's there, the side table has 3 spots, the sink. Those are all areas where the investigators cultured vancomycin-resistant enterococci in a clean room. Now, why is that a problem? Well, if you're a provider, you know that patients are vulnerable, regardless of who they are. If they're coming into a healthcare facility, if they're coming into an acute care hospital, they're vulnerable. They have an issue, some more severe than others, whether they're coming in with a myocardial infarction, or if they're coming in with complications from chemotherapy, they're vulnerable. My personal opinion, and I get choked up about this, and I'm not even a mother, but premature babies. They have to be the most vulnerable in the hospital if you've ever worked with them. Many of them only weigh 1 or 2 pounds. They are so fragile that sometimes touching them alone will cause them to have a cerebral hemorrhage. Their skin is so thin, it's like tissue, and it tears if you're not careful. When you put any kind of tape on it, you can see through the skin. You can see where the blood vessels are when you try to attempt IV access. So, in my humble opinion, they're the most vulnerable. And I want to share some research from the neonatal units that I had an opportunity to work in. So, these are the nurses. They're working with the most vulnerable patients that I feel in a hospital. And so what is on their hands? Because infections are a huge problem in a neonatal ICU. So I had opportunity to have hand cultures on nurses. I was part of a study where we were culturing the hands of nurses on a quarterly period. And we had 834 hand cultures. Half of them were obtained in a unit that was using alcohol hand sanitizer, and half were using antiseptic soap. And we cultured organisms off the nurses' hands. They were clean hands, I should tell you. We had them wash their hands or whatever product they were using on their unit before they were cultured. And we grew out 1,442 isolates. 88.8% were gram-positive, 6.6% gram-negative, and almost 5% were fungi on the hands of nurses caring for these babies. When you see and this is why I said we probably all have staph on our hands, of those nurses that participated in this study, and it was over 70% of them, 99% had staph epidermidis on their hands, 98% staph warneri, staph capitis. We also had the gram-negative, Acinetobacter, Klebsiella, and fungi. The fungi I found really disturbing, and though I knew which nurses they came from, and I don't think there's any hospital around now that allows artificial fingernails on nurses or wraps. And this nurse insisted, she had beautiful nails, she insisted they were her own, but she was the only one who repeatedly was culturing fungi off of her hands. So I think it was attributed to artificial wraps. Another disturbing piece of this is the hands of these nurses, that the susceptibility, the staph epidermidis, the staph warneri, lower numbers are bad in this stress. So that means the antibiotics aren't working when the numbers are low. So that was a problem. And again, we saw increased resistance to oxacillin and gentamicin. The predictors were the product they were using. We also found if nurses had damaged hands, and that kind of makes sense too. If it was their hands were cracked and dry, they were more likely to be harboring organisms. Well, okay, so now we know even when they clean their hands, nurses have all these organisms on them. I don't know what they have on them when they don't clean their hands, and that's a problem because here again, I have a couple decades of evidence, and there's a lot out there, but we can't get nurses, and I'm sure other providers, we can't get them to clean their hands. In 1999, Harvard said 37% of nurses were not compliant with hand hygiene. 2001, Boyle, 30%. 2002, Cohen, 32%. Ekman's, 2007, 70%, or 42%. Stone, 2007, 43%. And again, Kahn. I know the literature says it's difficult to change behavior, but, and I guess another thing is with their microorganisms. I guess there's that thought that what you can't see doesn't exist, but it's a problem. So we were watching talk about a Hawthorne, you know what the Hawthorne effect is? So if you're being observed, you do what they want you to do. Well, we were watching nurses in these neonatal units perform hand hygiene. And we were looking, and other individuals. We just took 1 month because they got a little upset and threw us out after a while, even though we had IRB approval and such. But we were looking at who was touching what and where. And we found, as one would expect, more than half the touches were by nurses, followed by visitors, or about 18%. Attendings, they were only touching these babies 7% of the time. But as one would think, nurses are there. They're there 24/7. They're always touching. And we looked at different levels of touch. And when we watched what the nurses were doing, because that's what we were interested in. We're interested in the nurses because they're there 24/7. 75% of the time, when nurses were caring for these babies, just touching little things outside the isolette, they did not wash their hands, they did not clean their hands, or use gloves. 48% of the time, they went inside that isolette and arranged things, whether it would be the bedding or maybe an IV tubing or whatever. They did not clean their hands and they did not use gloves. And 32% of the time, when they went in there and actually touched those babies, they did not clean their hands and they did not use their gloves. I remember what we saw when they did clean them. They had all those organisms. I can only imagine what was on them when they did not clean them. And some more evidence, because I know I have a shortened presentation here. We had, as I mentioned, this these hand cultures we had been collecting over this 2-year study. And we found a lot of staph warneri on the hands of nurses, which was unusual. We found that 44% of our samples were staph warneri, which is most previous reports have been 4 or 5%. Staph epidermidis, yes, but staph warneri was this was kind of a rare finding. So we wanted to look at this in a little more depth. So we looked at we had the hand samples from the nurses. We had 834. We had isolates, blood isolates from 647 from these infants. And we found out that 17 or 8% of them were staph warneri. So we wanted to compare the staph warneri. How does the staph warneri from the nurses compare to the staph warneri that's in the blood of the babies? So we did what was called, well, we didn't, the laboratory did, pulse field gel electrophoresis. So this is like DNA mapping of the organisms. So you can say you have a lot of findings in research, but this is like strong. This is strong stuff right here. So we had the 12 bloodstream infections available, 12 isolates from bloodstream infection, and we found that in those babies, 75% of them had a type A strain. So 75% of these babies had the same bug growing in their blood. We looked at nurses and neonates and nurse caregivers, and we found that 83% had type A. So then we thought, okay, we have also samples, hand cultures from adults in the community. We had blood samples from adults within the adult section of the hospital, because this was the children's hospital. So let's see what's going on here, because what is this staph warneri? Why are we finding this? And this is what we found. And this was frightening. I did this years ago, and it still makes me, if I was a nurse on that unit, I'd be quite upset. This is the DNA mapping. The first line down on the left is what they use for calibration. They call that a lambda marker. So the lane that has number 2, the column, I should say, that's 2, 3, 4, and 5, those are from babies. Now, the column number 2 is kind of different from everybody else, but if you look at column 3, 4, and 5, they're identical. Those babies, this is the image to show you that those babies were all sharing that same bug. Look at 6 and 7. That's a nurse. What was on her hands was now in the blood of these babies. It's a direct match. There's no disputing this. This is DNA mapping. There's no disputing it. And column 8 and 9, which is also hands of a nurse, is highly enough related that they would call that as a type A strain also. 10, 11, and 12 were from adult patients within the hospital. You can see they're totally different. I hope you can see them anyway. And 13, 14, and 15 were from hand cultures of people in the community. Now, I'm sorry if I get emotional, but I spent a lot of time on these units, and those babies died. 40% of those babies died. And they're linked to the hands of a nurse. There's no doubt about it. There's no doubt about it. I had to include this because not only am I passionate about these babies, I'm looking there and I'm thinking, okay, I don't know what the situation is here, but one person has gloves on and the other doesn't. So I don't know if they were required in this situation, what they were doing, or whatever. It was something I'd found online, but thought I would include it. In summary, nurse job-related burnout and job dissatisfaction are associated with workload. Nurses are missing important changes in patients' condition. They're failing to report important information at shift change. Burnout appears to be a possible explanation for the association between nurse staffing and infection. You can see, especially in these vulnerable babies, if there's going to be misses in practice or changes, it can be fatal. And that workload and its associated burnout jeopardizes patient safety. It's the bottom line. There's nothing else. Sorry if I was emotional, but those babies, it's sad to see anyone in any situation suffer from an adverse event, but when they're so tiny and vulnerable.